Mr. Chairman, my name is Mark Guimond. I'm with the Arthritis Foundation. We represent more than 50 million people nationwide with doctor-diagnosed arthritis. I'm here today to talk about network adequacy and try to define what that means. In particular, looking at the arthritis community. Arthritis is a chronic condition. It is a debilitating condition, and it is a treatable condition. What we look for in network adequacy is, generally speaking, access to care. Addressing the nature of the specialty of that care, the urgency of the care, and geographic accessibility, reasonable distance to seek care, and adequate numbers of specialists in the specialty area, and sufficient range of services. Fortunately for us, this bill does provide all of those aspects, and we're happy to see that. This is necessary as we see it. I think if you look at the world of juvenile arthritis, there are 5,600 kids with doctor-diagnosed juvenile arthritis in the state of Maryland. There are 9 board-certified pediatric rheumatologists to treat that entire population. Most of those board-certified pediatric rheumatologists are located in a central area and are not accessible to people who may be in rural areas of the state. When people look at their plans, when they're obtaining their plans, most of the time in our population they're looking at the cost. They have very expensive medication, including biologics, which can run to, on a family-wide basis, to hundreds or even thousands of dollars a month. And people are looking to try to get the plan that they can actually afford. If they can afford their plan, they get their medications, they can lead productive, meaningful lives. As they go into those plans, they may not have the accessibility that they need in finding a specialist. Particularly with arthritis, that is key. A rheumatologist, a board-certified rheumatologist, is critical to treating our population. So people go in and get the plan they can afford. They see that there may be rheumatologists in there. Then they find out there's a great distance. With a child, you have to take time off from work, time off from school. You may have to drive a great distance. And there may be great delays because the number of rheumatologists is so limited. So we believe in the substance of House Bill 990, and we do support it. I would like to give a personal example, too, in support of the bill. I am from Frederick, Maryland. I'm a resident of the state, and I do have arthritis myself. As I said, this can be a chronic, debilitating disease. It can be the difference, medication can be the difference between being in a wheelchair and sitting up here today talking to you. Before I joined the Arthritis Foundation, I went to look for health insurance. I went and I found a plan, and I thought it was good. It was affordable. It provided the network that I needed. I thought it was adequate. Everything was great. I looked through the book, started calling people locally to me, as the previous witness said. Every single person that I called was no longer taking new patients. When I did find somebody, it was a 6-month wait, it was a 9-month wait. The network was there, but it wasn't adequate. It really wasn't adequate at all, and it wasn't a network because it wasn't available. I feel like it's almost a bait-and-switch type of approach. If they're going to give network adequacy provisions and they're going to disclose who they cover, at least disclose whether or not that coverage is going to be available to somebody. Don't promise it and don't deliver it. I would be welcome to take any questions if you have any. Thank you.